Good afternoon, everyone. I'm Dr. Aaron Pollitt, the Provincial Head for Pathology and Laboratory Medicine at Cancer Care Ontario. On behalf of the Canadian Association of Pathologists, the Canadian Partnership Against Cancer, and Cancer Care Ontario, I would like to thank everyone to today's CE Cancer Protocol Education Session on Invasive Breast Cancer. To introduce our speaker and we get underway, I need to take care of a few housekeeping items. This session is being recorded, and a link to the recording will be circulated to all participants via email when it becomes available. My presentation and the recorded presentation are eligible for CME credits. Information for obtaining credits can be found in the session notice. Please note the CME certificates for each education session will only issue for 1 month from the presentation date. Please refer to the session notice for the exact deadline. Everyone's line has been automatically muted for today's presentation. We have a number of participants and will not be able to troubleshoot WebEx issues as part of this call. If you're experiencing technical difficulties, please call the WebEx support line. We invite you to submit questions at any time during the presentation using the chat feature. Chat instructions can also be found in the session notice. During the question and answer portion of the presentation, a session moderator will pose the submitted questions on your behalf for as time permits in the order in which they appear. In the please include the following information: your institution, the name of the individual posing the question, and the question itself. It is now my pleasure to introduce Dr. Penny Burns. Dr. Burns received her medical degree at Memorial University in Newfoundland in 1988. And completed her anatomic pathology residency at Dalhousie University in 1995. She practiced as a staff pathologist at the Halifax Infirmary until 1997, and the Division of Anatomic Pathology at the Queen Elizabeth II Health Science Centre, also in Halifax. She pursued subspecialty training in breast pathology at the University of Nottingham in 1999. Dr. Burns is an associate professor in the Department of Pathology at Dalhousie University. She served as program director for the Dalhousie Anatomic Pathology Residency Program from 2009 to 2014. Her clinical and academic interests include breast pathology, cytopathology, quality assurance for immunohistochemistry, and clinical pathologic correlation research. A member of the Nova Scotia Breast Screening Program Advisory Council, National Breast Cancer Pathology and Staging Multidisciplinary Expert Panel for the Partnership Against Cancer, and is co-chair of the Canadian Association of Pathologists Residents Course Committee. Without further ado, I'd like to ask Dr. Burns to give today's talk on invasive breast cancer.
Thank you for the kind introduction and for the opportunity to speak today. I apologize in advance. I'm recovering from a cold, so I'll try to keep my coughing to a minimum, but I might have to mute it. I'm to disclose. And our two learning objectives for today. First, I'm going to review the updated HAP protocol for invasive breast carcinoma, pointing out changes and clarifications for the protocol, and also to review the modifications for the most recent JCC TNM manual for breast carcinoma staging, the 8th edition. So the 8th edition of the TNM was released last fall, 2017, but the implementation date has been delayed until next January of 2018 to allow us time to update the synoptic reporting scheme. HAP invasive breast carcinoma protocol, the first protocol was released in 1986. You can see there was quite a long delay until the next version. The second version was released in 2009. In 2009, the updates have been more frequent. January 2016, there was an update. But in this present year, in 2016, it's been updated yet again to reflect changes made to the breast carcinoma staging in the 8th edition of the TNM system. Because there's been a delay for the implementation of the 8th edition of the TNM, all newly diagnosed cases that we encounter in 2017 should be staged using the 7th edition of the TNM system. CAP protocol, there's been a subtle change to the title. You can see that the updated title is to all invasive carcinomas of the breast, including microinvasive carcinoma with or without DCIS. It's changed from applies to all invasive carcinomas of the breast, including DCIS with microinvasion. So this captures the rare case where we might encounter microinvasive carcinoma without a background of DCIS. So both the CAP protocol and the staging system for breast carcinoma are to be used only for invasive breast carcinoma. And we know rarely it will encounter other types of tumors in the breast. Primary sarcomas of the breast be staged using the staging system for soft tissue sarcoma of trunk and extremities. It's rated that for phyllodes tumors, and I presume it's intended for malignant phyllodes tumors only, that they staged according to soft tissue sarcoma of unusual histologies and sites, and lymphomas for hematopoietic malignancies. So to use these types of tumors for the invasive carcinoma protocol. The case summary is intended for reporting the specimen with the largest focus of invasive carcinoma. We should use it for core biopsies, small incisional biopsies, or revision specimens after the larger focus of tumor has already been removed. There are 2 ipsilateral invasive carcinomas removed in 2 separate excisions. The summary should be used for the larger tumor. For bilateral carcinomas, then these are reported in 2 separate case summaries, one for each side. So these recommendations have not changed. If there is information from another specimen that we want to include in the case summary, for instance, reporting biomarker results from a previous core biopsy, then this should be stated in the comments section of the protocol and should provide the accession number for the case. If we have separate oriented surgeon margins that come separate from the main specimen, we can report it all together under the final margin status in margin section of the protocol. If it's difficult to do, or if the margins are not oriented, then we can describe the findings under additional pathologic findings. We'll run through the different items in the protocol for invasive breast carcinoma. The first component, the specimen identification, the type of procedure, the type of lymph node sampling if present, laterality, and tumor site, which is the quadrant or clock face position, changed at all. So these remain the same. For size, the options include, so we should report the size of the largest invasive carcinoma in the specimen. The options include microinvasion only, and microinvasion in breast carcinoma is invasive carcinoma that is 1 millimeter or smaller in size, or to report the dimension of the largest focus of invasion greater than 1 millimeter. No real invasive carcinoma. This might occur if the tumor has been completely removed by a previous biopsy or has responded to neoadjuvant treatment or be determined. And if we select cannot be determined, we should explain what the problem is. So to the tumor size, we should correlate the imaging features, the gross and microscopic findings, and for most cases, the microscopic measurement is the most accurate measurement. For multiple foci of invasion in the specimen, the size that we should list in the protocol is the size of the largest contiguous area of invasion. There are multiple foci of invasion. We should not add these together to arrive at tumor size. The invasive tumor size should not include adjacent DCIS. It should be measured to the nearest millimeter. If it is core biopsy or incisional biopsy and a larger area of invasion is present in the other specimen, then we should use this measurement for the PET classification if it's known. And so if you have a situation where most of the tumor has been removed by the previous core biopsy and little remains in the incisional specimen that you're reporting, the T size should be measured based on the largest focus of tumor in the previous biopsy. The diagram I've just taken from the explanatory notes of the protocol. It shows various situations that we might encounter when we're trying to determine the tumor size. The first panel shows an invasive carcinoma of an irregular contour, and the darker nodules represent DCIS around the perimeter of the tumor. So for T size, we would report the largest contiguous area of the invasive tumor not incorporating the DCIS. The second panel shows a small tumor that has been sampled by a previous core biopsy, and perhaps the largest focus tumor is in the core biopsy. I should not add these measurements together, but rather select the measurement that is the largest in either specimen, and that becomes the T stage or T size. In the third example, we have an invasive tumor that's been partly removed by the previous biopsy. We should not try to add the dimensions of the two specimens together because we really don't know how they fit together. Rather, select the largest dimension. In this case, it's probably the remaining tumor, and that would be our best estimate of tumor size. In this, we have multifocal tumors. The size will be the largest contiguous area of tumor. We should not add up the various additional foci. And then for this fifth example, we have an irregular contour of tumor. The large dimension would be measured across here. And there's a tumor that's been transected at surgery, and we wouldn't try to fit these together, measure both to add up. Rather, select the largest dimension, and that would be the T size. Identification in the updated protocol, as well as in the edition of the TNM, that states carcinoma larger than 1 millimeter but smaller than 1.5 millimeters. This should not be rounded down to 1 millimeter, but rather rounded up to 2 millimeters. When the tumor is not miscategorized as PT1MI. So remember that microinvasive carcinoma is invasive tumor that is 1 millimeter or smaller in size. So if we have a tumor that is larger than 1 millimeter, we should not round down. An example of DCIS with a small microinvasive focus of carcinoma. This measured 0.9 millimeters, so it's microinvasion. If we were to measure this and find that it measures 1.1 millimeters, we would not round down to 1 millimeter. Rather, for reporting the size, round up to 2 millimeters, and it would be a PT1A tumor. Solution of microinvasion as a single focus, we would provide that measurement. In multiple foci, try to quantify them and provide the range of sizes, including the largest focus. Sometimes, though, we might encounter a case where there is a bout of DCIS and innumerable foci of microinvasion. In a case like this, I suggest that we just try to estimate to the best that we can the number of foci and provide the largest size. And a comment describing the situation would be useful in such a situation. In some cases following neoadjuvant chemotherapy, there is no residual invasive carcinoma. There are two possible settings. YPTIS is what we would report if there is residual DCIS, and PT0 if there is no remaining invasive carcinoma in the setting. And in a situation like this, a protocol is not required, and it may be easier just to explain the findings in a descriptive report. Type. In the new protocol, the list of types has been expanded to reflect more entities listed in the WHO classification of breast carcinoma. This is a nice change, and it will help us reduce the use of other. Microinvasive carcinoma is listed on its own, whereas previously we had to choose between DCIS with microinvasion or LCIS with microinvasion. It's a list of the WHO classification of invasive carcinoma of the breast, the various tumor types that are listed in the most recent edition. And for the next two slides, I've copied the entities that we have now in our menu for the for histologic type. The entities in red are the new additions. So you'll see here microinvasive carcinoma is now a choice, or invasive carcinoma with extensive intraductal component. Note as well we have the various subtypes of metaplastic carcinoma as options, as well as some rarer tumor types such as adenoid cystic, apicarcinoma, secretory carcinoma. So this should reduce our use of the term other. The type that we select for the protocol corresponds to the largest focus of carcinoma in the specimen. If there are smaller carcinomas of a different type, then this should be included under the additional pathologic findings section. To grade in the protocol, there are no changes to this section. All carcinomas, all invasive carcinomas should be graded. We have the Nottingham grade. The grade that we report in the protocol corresponds to the largest invasive tumor in the specimen. If the smaller foci of invasion of a different grade, then this will be reported under additional pathologic findings. For tumor locality, this has not changed. Our options include single focus of invasive carcinoma, multiple foci of invasive carcinoma, and we would report the number of foci and their sizes. No invasive carcinoma, if that's the situation, or cannot be determined, in which case we would explain why. If the invasive carcinomas size, grade, ERP, and HER2 status should pertain to the largest invasive carcinoma. If there are smaller invasive carcinomas that differ in any of these features, then this should be included in additional pathologic findings or in comments. This comes from the other notes section of the protocol, showing different examples of tumor focality. The first example is a case of an extensive intraductal component with multiple small foci of invasion. You have a main tumor with small satellite nodules, so for the T size we would measure across the largest focus. This is the main invasive carcinoma, and then smaller foci that are associated with lymphovascular invasion. Fourth panel, we have two invasive tumors that have different phenotypes. So we select the larger tumor to report the prognostic factors within the protocol, and for those of the smaller tumor, we would describe these under additional pathologic findings. In the fifth example, we have a case where the patient has had neoadjuvant chemotherapy, a residual tumor bed, and multifocal residual invasive carcinoma. So the largest focus would now be measured for the IPT size. And there's an example of a tumor that's been transected. And at times in this situation, it may be difficult or impossible to determine if there was more than one tumor in that specimen, especially if it was received in multiple fragments or there's a lot of cautery artifact. So the next section, DCIS, there hasn't been significant changes to this section. The reason that we want to describe DCIS when our lesion is invasive carcinoma is if there's extensive DCIS, there is a greater risk of local recurrence for patients who have undergone breast conservation surgery. And this occurs because it's perhaps some of the DCIS may have been left behind. It's really important to report the details of DCIS, what the predominant find an excision, or if it's extensive. For instance, an extensive intraductal component with microinvasion or a small T1A tumor. The DCIS are less clinically relevant with a minimal component of the invasive carcinoma, and if the patient has had a mastectomy. And in this setting, report all the various elements of DCIS are optional. So we report either DCIS is present or not, and if it's present, is extensive intraductal component, yellow, and is only DCIS present after neoadjuvant treatment. This shows various settings of the extent of DCIS. The first two represent examples of an extensive intraductal component, or EIC. The first example, we have a background of extensive DCIS and invasive carcinoma where there's a significant amount of DCIS in the interior of the tumor. an example of EIC is a background of extensive DCIS with small foci of invasion or microinvasion. Tumor has only focal DCIS, and in this situation, reporting and describing the elements are optional. And the fourth example, we have an invasive carcinoma, and as well we have extensive DCIS off to the side. It doesn't really meet the criteria of EIC positive, but you can see that it is extensive, and this is something that we would want to measure and describe. When describing DCIS, we want to measure this dimension in millimeters. Whether we provide other dimensions of DCIS is optional. We report the number of blocks with DCIS as a ratio of the number of tissue blocks examined. And for a size of DCIS, this is best done when the specimens have been growthed in some form of serial sequential sampling with the block mapped out on a diagram of the specimen or specimen X-ray, and then we were able to measure the extent of DCIS and provide a reasonable estimate of its extent. We would report the various architectural patterns, the near grade, the presence or absence and degree of necrosis, and whether or not we see LCIS in the specimen as well. And microscopic extent of the tumor pertains to skin and muscle, and whether the tumor involves these structures, and is only required in the protocol if the structures are present and involved. Skin or muscle is present in a breast excisional specimen, then this should be described in the gross report, as well as the relationship of the tumor to the skin and or muscle. So it is present in a specimen and it's involved. Our options to describe the involvement include if a carcinoma directly involves the dermis or without skin ulceration, and this does not change.
Can you go chat for a second? Click on chat.
Invasive carcinoma directly invades the dermis or epidermis with cutaneous ulceration. This is staged as T4B.
Who is this?
The lateral satellite skin nodule present.
Sorry, could you hold 1 second? I think that we're having technical difficulties. I'm going to try to mute everybody, but
okay.
Except Dr. Barnes. Sorry, 1 sec.
Get out of the screen. I don't have to do that.
No.
Line. It does. I think you can probably continue.
Okay. So we're back on? Okay.
I can hear you.
All right. So I'll just finish off this slide. So reporting of skin involvement, the options when there is invasive carcinoma involving the skin. So if there's no cutaneous ulceration, it does not change the T size. If there is overall ulceration, this stages the tumor to T4B. And as well, if there are satellites of tumor in the skin that are separate from the main tumor, that might require a change in stage. However, this is clarified in the protocol and in the staging manual. So for satellite skin nodules separate from the primary tumor, must be identified macroscopically for category of T4B. So this is a clarification in the protocol. We need to see them at the gross level. If we only see this microscopically, then the T stage is based on the largest primary tumor. For more of the macroscopic and microscopic extent, for nipple DCIS, this is patch disease of the nipple, and this does not change the T stage of invasive carcinoma. If it is present and involved with the tumor, our options include for carcinoma invade skeletal muscle or carcinoma invade skeletal muscle into the chest wall, and in this situation, the T stage is T4A. Now, most of the time when there's muscle attached to a mastectomy or a wide excision, it is pectoralis muscle, and this is not considered chest wall tissue. Or chest wall is excision into the intercostal muscles or deeper, and this is usually not the tissue excision that we receive in most large specimens. T4A stage is generally established with imaging that information before collecting that the chest wall invasion. For reporting of margins in the protocol, there's been no change. Our options are margins not be assessed if the specimen was received in a fragmented fashion, and report the margins of the invasive component and DCIS if it's present separately. If patients are uninvolved, we want to report the closest margins and the distance from the tumor in millimeters. If the margins are involved, we need to specify which margins are involved, and there is a description of the extent of involvement, which I'll mention in a moment. For DCIS, if DCIS is present and uninvolved, we want to report the distance of the closest margins in millimeters. If the margins are involved with DCIS, we need to report which specific margins are involved and to what extent. Margin status is listed as positive if there is ink directly on the tumor, so either the invasive or in situ tumor. The protocol, however, we are allowed to express distances in greater than or less than measurements, so greater than 10 millimeters or less than 1 millimeter are options as well. The protocol has described as the extent of margin involvement is as follows. Focal involvement is described as one focal area of carcinoma at the margin measuring less than 4 millimeters. Extensive is described as carcinoma at the margin over a broad front greater than 5 millimeters. Minimal or moderate is in between, that they describe as 2 or more foci of carcinoma at the margin. I'm fairly certain not all of our surgeons and oncologists know the details of this description, so I would report this as it's listed, but maybe comment, describe specifically the degree of involvement, because I don't think everyone knows these, isn't used to them at the present time. Report nodes is required if the lymph nodes have been submitted with a specimen. We report the total number of lymph nodes examined and the total number of sentinel lymph nodes examined. So remember, evaluating sentinel lymph nodes, one of the most important things we can do in the assessment is at the gross level. We want to make sure the lymph nodes are thinly sliced, no greater than 2 millimeter intervals, in order for us to identify the most clinically relevant metastatic deposits, which are the macrometastases larger than 2 millimeters in size. In grossly positive nodes, it's not essential to block these in their entirety. we would record the size and submit at least one section that includes any areas that might represent extranodal extension. Endoscopic evaluation of sentinel nodes, we need to evaluate at least one H&E level of each multisected lymph node. Whether we evaluate multiple levels through the block or perform immunohistochemistry is at our discretion. So for breast carcinoma, there's a few things to remember when assessing sentinel nodes. Tumor nodules in the axillary fat without any identifiable lymph node parenchyma are classified as regional lymph node metastasis in breast cancer. Mammary lymph nodes are also included with axillary nodes for the PN classification. And if we see direct extension of the primary tumor into a regional node, is classified as node positive. So once we've evaluated the lymph nodes, we have to fill out this part of the protocol to list the number of lymph nodes with macrometastases, and these would be greater than 2 millimeters. The number of lymph nodes with micrometastases, which are deposits greater than 0.2 millimeters and up to 2 millimeters in size, or if there are more than 200 tumor cells on a section of that node, and nodes with isolated tumor cells, and these measure are smaller than or up to 0.2 millimeters, 400 tumor cells or fewer on the slide. And we then want to report the size of the largest metastatic deposit. Here's an isolated tumor cell cluster, which measures less than 0.2 millimeters, a micrometastasis, which is greater than 0.2 millimeters and less than 2 millimeters in size. Now, there's a change in the new protocol. So if we have a case where we've identified macrometastases or micrometastases, we don't have to tally up the other additional lymph nodes with isolated tumor cell clusters. So this doesn't really change the clinical management. The call is recommended, though, that if we have a case where the sentinel lymph nodes are not involved and we identify tumor deposits in a non-sentinel lymph node, that this should be described in a note. This should be a very rare event. Possible causes are that the true sentinel lymph node has not been identified by the tracer, that there's unusual lymphatic drainage, and this might occur if the patient's had previous surgery, such as reduction or cosmetic surgery. There could have been technical failure, and the tracer just did not find that sentinel node. And this would be important for the surgeons to take note for their quality assurance follow-up in their sentinel lymph node identification. Remember, the size of the metastatic deposit for the N classification is based on the largest contiguous cluster of tumor cells, not the size of the involved lymph node. However, if we have an overall volume of tumor in lymph nodes, say multiple tumor deposits that should merit a higher N category, then this is up to judgment. This might occur if you have a case where there's multiple micrometastases scattered throughout the tumor. You may feel that this is probably regarded as a macrometastasis, in which case you would describe the situation in a note. The size of the metastasis, not the size of the lymph node, is used for PN category. Examples of various situations. We have a lymph node with multiple tumor deposits. It's the largest one that we use for PN. In the second panel, we have a lymph node that has a scattered panel of small isolated tumor cell clusters. If we estimate that there's more than 200 cells in this lymph node section, then we would decide that this should be classified as micrometastasis. Here we have a lymph node with a tumor deposit with extracapsular extension, so we would measure the greatest size across this nodule for the N category. In the last example, we have a lymph node that's not involved and a tumor deposit sitting in the axillary 5, and we count this as a positive node. We have involved lymph nodes. We need to report whether or not there is extranodal extension of the tumor. I think it's useful. Our clinicians often want to know what the extent of this is. Is it focal? Is it diffuse? Are there multiple nodes with extranodal extension of tumor? to describe how we've evaluated the sentinel nodes, one H&E level, multiple levels, did we perform IHC, so that stays the same in the protocol. That deals with treatment effect, response to pre-surgical or neoadjuvant therapy. In Breast, the options include no known pre-surgical therapy, no definite response to pre-surgical therapy of the invasive carcinoma, probable definite response, and finally, no residual tumor after pre-surgical therapy. There's been an indication in the protocol and in the staging manual that reminds us that it's the largest focus of residual invasive carcinoma, if present, that is used to determine the YPT category. We do not include the associated treatment-related fibrosis when measuring this. Classification to remember. Here's an example of a patient. It's a mastectomy specimen. The patient had neoadjuvant treatment, and this is a section showing this kind of loose fibrosis of the tumor bed. It's a bit cellular in areas. Higher power, we can see some residual single-degenerated tumor cells in a smaller cluster. So evaluating sections of the tumor bed, we need to look for the largest contiguous focus of residual tumor that we will use for the YPT category. The fibrosis in this measurement. This is an example of a section of tumor, a patient who had neoadjuvant chemotherapy. There was an obvious response, pathologic response to treatment of this tumor. Size was used based on the gross measurement of 4 centimeters in this case. For the lymph nodes, the options include no pre-surgical therapy, no lymph nodes removed, definite response to pre-surgical therapy of metastatic carcinoma, probable definite response, no node metastasis with fibrous scarring possibly related to prior nodal metastasis, or complete response, no metastasis and no prominent fibrosis in the lymph nodes. So this has not changed. Verification in the protocol and in the staging manual, which reminds us that it's the largest focus of residual tumor in the lymph nodes if it's present, is used to determine the YPN category. Do not include treatment-related fibrosis in this measurement. And of a lymph node in a patient who had neoadjuvant treatment, there is some treatment-related fibrosis and small deposits of tumor cells. So we would use the largest of these for the YPN category, not include the fibrosis in the measurement. In select cases following neoadjuvant chemotherapy, we need to identify the tumor bed grossly, sample it thoroughly, and map out how the blocks were sampled on a diagram so that we can estimate the degree of pathologic response. We want to estimate the percentage reduction of tumor cellularity by sampling this, and when possible, to document a pre-treatment PT category. So was there a treatment diagnosis of inflammatory carcinoma or a large locally advanced tumor? The protocol recommends that we repeat biomarker studies if the previous results were negative prior to treatment. I recommend that we repeat the biomarker studies regardless, because sometimes tumors can be heterogeneous or multifocal with different types, and we wouldn't know this unless we were to repeat the EPR and HER2 on residual carcinoma if it's present. If there was any residual disease in the lymph nodes, such as metastasis or isolated tumor cells, this is not. We should not classify this as pathologic complete response. And as this is not specifically addressed in the protocol or in the 8th edition of the TNM update, residual vascular invasion should not be classified as a pathologic complete response. To a number of review articles that have addressed this issue. So what kind of residual tumor it should preclude a diagnosis of pathologic complete response to treatment. It was classified as inflammatory carcinoma prior to treatment, T4D, then it remains YC T4D post-treatment, and the YPT classification reflects the extent of residual disease, if it's present, or complete response. Vascular invasion. This has not changed in the updated protocol. Again, look for LVI usually at the leading edge of the tumor where it's really seen, or perhaps widely farther away from the leading edge of the tumor. And lesions are not identified or present. I think it's useful to provide some kind of description of the extent of LVI, whether it's focal or extensive. This might impact on treatment decisions. Said that there isn't a definition of extensive LVI standardized. For DCIS, the options are no skin is present, not identified or present. Histologic staging. So these descriptors, M for multiple, R for recurrent, Y for post-treatment remain the same. There's been a change in the staging manual. PCIS, LCIS has been removed. So PCIS now refers to PTIS, DCIS, or PTIS Paget when we see Paget's disease without associated invasive carcinoma or DCIS. The other ET categories have not changed. The only thing that's changed is that there's been a clarification for PT4D, where ipsilateral skin nodules tumor have to be macroscopically identified for that stage category. Their new suffix, the former suffix SN, is the same, which refers to sentinel nodes. So if you have a case with sentinel lymph nodes, for us to be able to use the SN modifier, there needs to be 5 sentinel nodes in the in the specimen. If there are 6 or more lymph nodes removed, sentinel or non-sentinel nodes, then we do not use the SN suffix descriptor. The new descriptor is small f. This refers to nodal metastasis that's confirmed by FNA or core needle biopsy, and this is typically done in the workup of suspicious lymph nodes prior to neoadjuvant treatment. So now that can be described using the small f descriptor. Other N categories, EN categories remain the same. Protocol, however, we now have a complete list of the various PN categories in the menu. The ones I've bolded in red are new added. They're not different. They're just optional to include in the protocol. Any instance that we might have a supraclavicular lymph node or internal mammary lymph node with a specimen to report. At PM, there has been a change, which is that MX, referring to metastasis unknown, and PM0 have been eliminated. So our only choice is PM1, and this is if we have a case where there has been histologically proven metastasis, then 0.2 millimeters, and if this is present and we're aware of it, we would specify the site. PMOI plus refers to circulating tumors identified in bone marrow, if that's available, and the prognostic significance of this is unknown. I think in our center would be a rare entity to know about when we're reporting a case. Under pathologic findings, it's the section that we would describe the details of multiple invasive carcinomas, if the prognostic factors differ, biomarker results if they were performed on the previous core biopsy, and also to report the presence of a core biopsy tract in the specimen and other relevant lesions. For studies, we still use the CAP breast biomarker template to report ER/PR, HER2, IHC, and FISH results. The next items of the protocol remain the same, so calcifications and where they're present. The pertinent clinical history options remain and are optional. I'm going to move on to outline the main changes that have been made in the addition of the TNM for breast carcinoma staging. And these have been addressed because they've been updated in the protocol. The big one for the 8th edition of the TNM is this on the slide. There are now two stage groups for breast carcinoma, an anatomic stage group and a prognostic stage group. The anatomic stage group is based solely on the anatomic extent of the cancer as defined by T, N, and M. And this type of stage group is mainly aimed to be used in parts of the world where there may not be biomarker testing available or detailed pathologic assessment. The rest of the world, including North America, will be utilizing the prognostic stage group table. And this table that's been developed based on population data for patients treated with breast carcinoma with the appropriate endocrine or systemic chemotherapy. And this includes anatomic extent, T and M, and ER/PR and HER2 status. And it's this stage group will be referred for patient care and will be monitored by tumor registry. So for this to happen, we need to continue to perform biomarkers on all invasive carcinomas using the appropriate assays whenever possible. Well, the results of multi-gene panels, when available, are included in some instances of stage modifiers. So be incorporated into the staging system for patients who have hormone receptor positive, HER2 negative, lymph node negative disease, and whose tumors fall into the low risk or low recurrence scores with multi-gene panel testing. And in this setting, the tumor falls into the same prognostic category as any tumor that is T1A or T1B, N0, M0, regardless of the T size. So in this setting only that multi-gene panels will be incorporated as stage modifier. The stage group essentially incorporates all this information and patients with similar prognosis that are to be used by the clinicians for treatment decisions. This is a photocopy of my new TNM manual, and this is a picture of what the prognostic stage group table looks like. This actually is 4 pages long, and this is a poor photocopy reproduction of one of the pages, but you can see that it has under the columns T stage, N stage, M stage, grade, HER status, ER status, PR status, and if you match this up for a particular patient, you'll identify their prognostic stage group, and if they happen to have had a multi-gene panel with a low recurrence score, then this is incorporated as well. So that is new for the staging manual for breast carcinoma. I'll just run through the other clarifications, many of which I've covered. So the next biggest one is that LCIS has been removed as a symbol of PTIS. In the description, they also note that pleomorphic or variant LCIS will no longer not be included as TIS. So we'll have to wait to see whether we no longer will be using the DCIS protocol to report variant LCIS as we currently can. Wait for that next update. So as well, not to round down tumors measured between 1 and 1.5 millimeters, to round this down to microinvasion. Microinvasion is a tumor that is no greater than 1 millimeter. And invasive tumor size or T size should be the largest contiguous focus of invasion. Do not include smaller microscopic satellite foci around the primary tumor to achieve your T size. If no foci, then we'll use the modifier M. That for slight tumor nodules, they must be macroscopically identified to categorize as T4B. And measurement of lymph node metastasis, we want to measure the largest tumor deposit, not measure across multiple deposits or N category. PO is no longer a valid category. We can use P0 is no longer a valid category. We can use PM1 if there is histologically confirmed metastasis. And follow-up treatment, YPT and YPM categories are based on the largest focus of residual invasive or metastatic tumor. not include treatment-related fibrosis. If there's multiple foci of invasive carcinoma in the breast, we use the M modifier, and we try to report the pre-treatment CT category when we can. If there's any invasive carcinoma or metastatic carcinoma, including ITCs in the lymph nodes, this precludes complete pathologic response. And while it's not stated, I would suggest that LVI also is not a complete pathologic response to treatment. If a patient has documented clinical or pathologic metastatic disease prior to therapy, the clinical M1 category remains, regardless of response to treatment. And that is good. Are there any questions? Waiting for questions. I have included references, including a couple of updated articles dealing with following neoadjuvant treatment for breast carcinoma.
No.
Hi, Doctor. So Julia at CPAC should be receiving the questions via the chat window. So hopefully,
Okay.
If
wait for her to see if there are any questions.
Yeah, if they're connected, which they hopefully still are.
Okay.
Should be reading the questions.
Here.
We can go through them.
It's always the danger with this technology. No one sent me an email to say that it's all gone downhill.
Oh, hello?
Oh.
Hi, we were having a lot of technical difficulties. Sorry about that.
Okay, did it crash or was
the WebEx kind of just acted wonky and was unmuting people and mute them. It was just a whole issue. But we've had them unmute us. So I have the chat open, and I'm looking at the questions now. So what I will do is I will read out questions, and then if you can just answer them, that would be great.
All right. Okay.
So I'm going to read the first question from Rao. Sorry if I'm mispronouncing the name. For encapsulated or cyst capillary carcinomas without invasion, should we use the invasive or CIS protocol? Or CIS protocol, sorry.
Right.
Please.
That's a great question. So if an encapsulated papillary carcinoma with frank associated conventional invasive carcinoma, you would use the invasive carcinoma protocol, and the PT stage would be based on the invasive component only. You would not include the encapsulated papillary carcinoma component in the T size. If you think there was an invasive or encapsulated papillary carcinoma without associated conventional invasion, then you would use the DCIS protocol.
Okay. The next question is, what is the significance of LVI at a margin?
That's a good question. So LVI is kind of a systemic finding, and the surgeons will not back for LVI at a margin. I think it's probably worth noting in a comment just to get an indication that there probably is a high risk of local recurrence in the mastectomy flap if that's the procedure that's done. I think if there's extensive LVI and you're seeing it at a margin, it's starting to point in the direction of systemic therapy. Well, it's not really a part of the protocol, I think it's probably worth noting in a comment.
The next question is, report the margin status in a multifocal breast cancer where the large tumor is away from the margin. One of the smaller tumors is closer to the margin. The P stage applies to the larger tumor, but how about the distance to the closest margin? In that case, it's related to the larger tumor, but rather to the other of the smaller tumors.
Yes. So I think I would report in the section the distance to the smaller tumor. And in a comment, you could say that the larger tumor is well excised, but the smaller tumor is however many millimeters it is from the closest margin, because it's still a close margin. And that would give some information about the proximity of surgical margins and whether or not a re-excision is necessary.
Okay. The next question is, will you use the DCIS synoptic to report pure encapsulated capillary carcinoma?
The question is, would we use the DCIS synoptic protocol for encapsulated papillary carcinoma? Is that the question?
Yes, that's correct.
Oh, yes, you would. If it's just encapsulated papillary carcinoma, that's intermediate grade in cytology, there's no frank conventional invasion, you would report that with using the DCIS protocol.
Okay. Next question is, how would you use the DCIS synoptic to report pure encapsulated capillary carcinoma?
I think the same question.
Sorry, I think I just answered that. Okay, sorry, my apologies. In prognostic staging inclusion of oncotypes, DX score is criteria 11 or 18?
You know, I think whatever falls into the low risk score, I don't remember where the threshold lies myself. So whatever is the low risk would be included as a stage modifier, assuming that the patient has hormone receptor positive, HER2 negative, node negative disease.
Okay.
Why DCIS, not PTIS?
No, that's a good question. I mean, when you read the discussion in the manual, I guess classic LCIS really, it's regarded as a non-obligate marker of increased risk. Surgeons are not going back to excise classic LCIS. And the author's argument for not including pleomorphic or other variant LCIS as yes, disease because the data is so limited, very few studies, and so this is what recommendation is not to include it as ETIS. It's because there's not a lot of information about it. We have to wait to see how the panel, the expert panel, deals with this when they go to update the DCIS protocol, whether or not it's still we still report it using that protocol or using some other description.
Sorry, for DCIS size measurements, if there are foci in slice 2 and slice 6, nothing in between, do you use the full size of tissue between slice 2 to 6 for DCIS size, or just 2 foci reported separately? Yeah,
that's a really good question, and that type of situation is pretty uncommon. Usually when we have sections of DCIS, it's continuous throughout the specimen, and there's no sort of skip lesions in between. Skip lesions up to 1 centimeter have been described in low to intermediate grade DCIS, but it sounds from this description that it's more than 1 centimeter if you have it in slice 2 and nothing in the slide 6. So I wonder whether or not dealing with a multifocal DCIS. So I wouldn't measure across the benign areas of the specimen, but I would wonder if you have separate foci of DCIS in that specimen, and then you would measure those instead.
Okay, next question is, how should we categorize pleomorphic LCS with partial E category staining?
Pleomorphic LCIS, you see sort of with E-cadherin, you may see some kind of variant staining or variant expression of E-cadherin if it's lobular carcinoma in situ. It may not be completely absent. You may see some partial staining, and that still could be part of LCIS. If you think if it fits and you think it's lobular carcinoma in situ pleomorphic, then that's how I would report it.
Okay. Next question is, how do you define a satellite nodule? Do you classify satellite nodules as multifocal tumor?
Yes. So satellite nodules would be multiple foci, usually around a main tumor. And if it's in the skin, it would be foci of carcinoma in the dermis as a satellite nodule. Kept on talking about that only is that for the upstage this as T4 carcinoma, you need to see this grossly in the skin to call it a cutaneous satellite nodule.
Next question is, how do you report two primary carcinomas in the same breast? And do you say which one is present in the lymph node?
That's a good question. So the limitations of the protocols is that we're kind of recommended that we report the largest focus carcinoma, regardless of all the other prognostic factors, using the protocol. And that if you find a second tumor that differs in the prognostic factors, you describe that in a comment or in other pathologic findings. Then I guess lymph nodes look more like the second smaller tumor. I mean, morphologically looks like a phenotype of the smaller tumor. I think it would be worthwhile noting that in a comment. So that's a larger tumor with lobular carcinoma, and you've got a smaller high-grade ductal carcinoma, and the nodal disease looks like it's ductal. I think that would reflect the biology of the smaller tumor, and I think I would comment on that.
The question is, how do you determine the T stage if we have single scattered cells and multiple consecutive slices of tissue in the background of fibrosis?
So I'm presuming that would be in the set of post-neoadjuvant treatment, and if that's the case, then it would be YPT for microinvasion, because if nothing is larger than 1 millimeter in extent, then you usually have multiple microinvasive foci. And then an M for multiple. I think question.
Okay, the next question is, how do you find satellite nodules? And do you classify satellite nodules as, I think that question was actually asked from before, as multifocal tumor. That sounds familiar.
Yes,
okay.
Multifocal tumor.
Okay. The next question is, in case of low how to determine the size of nodule metastasis if you have many single cells in the subcapsular sinus?
Okay, so I think the question is nodal deposits, small microscopic nodal deposits in the subcapsular sinus. Sorry, question?
Yep, sure. So the question was, in of lobar carcinomas, how to determine the size of nodal metastasis if have many single cells in the subcapsular sinuses?
Okay, good question. So often it's lobular carcinoma that has that scattered pattern of metastasis. I think a keratin stain in that setting is helpful just to better delineate where the tumor cells are. So T and size of the largest contiguous focus would be used. However, if in one full-face section, multi-sected node, you think you've got more than 200 cells, then you can upscale that to micrometastasis. So it's on the largest contiguous focus and how many cells that you estimate are on the slide.
Do you report LCIS, whether in biopsy or excision?
If you see LCIS in either, I would report it. So if we see LCIS in a core biopsy, it depends on the clinical setting, whether or not the patients are followed with mammography or whether or not the surgeon decides to do a localization excision. They might decide to excise if there's a discordance with the imaging findings. And I would report it in excision as a finding. It's a marker of increased bilateral breast carcinoma risk, but we don't need to report the margins for classic LCIS.
The next question is, how exactly do you measure extranodal extension?
Well, I guess you can measure its greatest extent outside of the lymph node. There aren't any sort of hard and fast rules on describing the extent of extranodal extension. Diffuse are options. Diffuse might mean that it's widely extending beyond. I mean, you could be more specific, measure the greatest dimension up to that extends beyond the lymph node. The reason that clinicians are interested in this is in planning the radiation.
Okay. Next question is, when tumor is in the lymph node and in the breast, which should be used for HER2? If the breast tumor is negative for HER2, should the test be repeated with lymph node?
Usually the primary tumor and the nodal metastasis are quite concordant for HER2 expression. So it would, I think I might just pick the best preserved specimen. If we monitor the cold ischemic time and the tumor in the breast is well preserved, and there's a larger amount of it there, then I might be inclined to do it on that. But if you have a situation where the primary tumor is necrotic and degenerated, then it may be that the nodal deposit is the better one to test. So I think it depends on the situation, but they generally, the results are fairly concordant. And no, I wouldn't repeat it. If it was negative in one specimen and you were satisfied with the pre-analytic handling and controls and so forth, I don't think you need to repeat it.
Okay. Next question is, do you have any advice or how much effort do you put to find residual tumor in a neoadjuvant breast case?
Right. If you have a case that is usually a complete pathologic response to treatment, I think you have to have a good gross look at the tumor bed and at least put one full face section of the entire tumor bed through. Look for residual carcinoma. Would go back to the gross specimen and make sure that there was nothing missing, and I would make sure the tumor bed was well sampled.
Okay. Cases of invasive lobular carcinomas that have a multifocal growth pattern, how do you determine the size?
It can be difficult when you've got multiple small carcinomas. Well, excuse me, you might go to look at the growth report with the largest growth measurement was, and that often lobular carcinomas are large in growth measurement because they don't incite a desmoplastic reaction, and then our best estimate would be the largest contiguous focus of carcinoma. Necessary, you might want to, if you've got a big tumor, sample it in more than one cassette so that you can measure across a couple of blocks to find the extent. Ultimately, it's going to be your best estimate.
Is there any value to measuring extranodal extension?
I think some description of how extensive it is. Again, it probably depends on your clinicians. Ours like to know the relative extent of extranodal extension of tumor. So that's the reason. If your clinicians are interested in knowing, then I would provide the measurement.
In the prognostic staging inclusion of Oncotype DX score, is the criteria 11 or 18, and you justify the decision for that?
I think that question already, and I'm not sure. I think whatever, I can't remember the cut points for the low recurrence breast. I can't answer that specifically. I don't remember the numbers.
The next question is, would you use DCIS synoptic to report pleomorphic LCIS cases?
Well, I think now I would. As the 8th edition of the TNM will not be implemented until January 1st of 2018, we are still using the 7th edition of the staging system, which includes LCIS for now. Until the DCIS protocol is updated, I think I would continue for the moment. And then we'll see what happens this current year if there's been a recommendation not to.
Is pleomorphic LCIS only? So do you not use the PTN at all?
Right, same question. And again, in the so in 2018, using the TNM, LCIS will be removed from the TNM system. So, but this current year, in 2017, we'll still use the 7th edition of the TNM, so I think we can still report it as such, and then in 2018 we will not. And again, we'll just have to wait to see how the DCIS protocol, what changes are made when that's updated.
When surgeons provide 3 sentinel nodes in parts A to C and 4 non-sentinel nodes in part D, should we use non-sentinel node sampling because they are more than 5?
Yeah, so for that situation, you would use the SN descriptor because there are more than 5 lymph nodes. That's exactly. So you can only use the SN descriptor when there are 5 lymph nodes in total or fewer.
Okay, does the inclusion of the oncotype recurrence score imply that the pathologist should send the relevant cases out to reflex testing, or should this still be initiated by the oncologist?
Yes, we should not do this on our own. This should only be done to the oncologist. We should not be doing this on our own. That's only information that they're going to use when relevant in the prognostic group when adding on further treatment.
Okay. Is the positive margin for DCIS considered ink on carcinoma or DCIS, or then 2 millimeters, which is the definition our clinical colleagues use?
Right. So it's reported if it's ink on margin, positive, and if it's less than 2 millimeters, and they're going to, you can report the actual measurement if it's less than 1 millimeter or 2 millimeters, and that to them if they're going to act on the close margin for excision. So, but I wouldn't call it positive if there is still ink directly on the DCIS. But it's like, sounds like there's an understanding about what threshold is for re-excision.
Okay, the question is, how would you classify invasive tumor with H&E features of lobular carcinomas while E cadherin is strongly positive?
Okay, that's a good question. This has been addressed in a couple of review articles addressing the pitfalls and uses of E-cadherin immunohistochemistry. And you have a carcinoma that morphologically looks like a lobular carcinoma. Really, it can express E-cadherin. Usually it's negative or it has some aberrant or partial staining, but rarely it can be positive. So I think you really have to rely on the morphology in the tumor classification.
And there was another question, if you can go back to the reference slide.
Okay.
Are there any additional questions? If so, you could just in the chat part, and I will read them out. A couple minutes and see if there's any additional questions.
Okay.
Is there questions? If not, we'll ending presentations if there's no more questions, we'll wait another minute or two.
Mine's muted.
I think that's all the questions we have.
On behalf of the Canadian Association of Pathologists, the Canadian Partnership Against Cancer, and Cancer Ontario, I'd like to thank Dr. Barnes for a great presentation today. As a reminder, both the live and recorded presentations are eligible for continuing education credits. In order to request your certificate of participation, please provide your name and email address at the link included in the session notice. You'll also find an optional session evaluation form, which we encourage you to complete. The information collected through the session evaluations allows us to ensure that these sessions continue to be informative and relevant to your practice. We appreciate your feedback and suggestions. And see the session notice for more information. So bring your attention to the upcoming sessions. Next week we would have Dr. James Brierley talking in general about the TMN classification 8th edition. And the following week we have an update on thyroid. So then 2 other sessions which will be at towards the end of March. So thank you everybody for your participation today.